Hello, everyone, and welcome to week two. This is lecture one. We're going to be spending time the next several weeks looking at just a specific neurotransmitter each week. This is to kind of help you prepare for um, future courses and also your role as a PMHNP. Having a good comprehensive understanding of these neurotransmitters is invaluable as you practice and care for those with a mental health issue. Our first neurotransmitter then is norepinephrine and epinephrine. They are different. So norepinephrine was first identified in the 1940s by a Swedish physiologist, Ulf van Euler. It's also known as noradrenaline, and it's a neurotransmitter of the brain that plays an essential role in the regulation of arousal, attention, cognitive function, and stress reactions. It's also a hormone. But for our purposes, we're going to be focusing on the neurotransmitter part of it. But it is a hormone um, that's produced in the adrenal glands, and it's part of the sympathetic nervous system with a fight or flight response. Um, and norepinephrine is a neurotransmitter in both the peripheral and the central nervous system. Norepinephrine produces many effects in the body, and the most notable being those associated with, as I said, the fight or flight response to perceived danger. And the effects of norepinephrine and epinephrine are mediated by the family of adrenergic receptors. The adrenergic system has been implicated in the pathogenesis of some significant neuropsychiatric disorders, which we'll take a look at, and has been an important pharmacologic target in various psychiatric, neurologic, and cardiopulmonary disorders. So norepinephrine is produced in the locus coeruleus of the pons. You see that here. And stress activates the locus coeruleus, which results in increased norepinephrine release. As you can see, these little projections here. Um, and this happens along the sites of the locus coeruleus, including the amygdala, the prefrontal cortex, and the hippocampus. This regulation may occur with early childhood maltreatment. So some common psychiatric disorders associated with norepinephrine. And I want to stress that because a lot of what we do know a lot, but a lot of it is still a working theory. Um, and things have been implicated, but we don't know for sure. But these are working things that we do believe so far, and that may change. So, common psychiatric disorders associated with norepinephrine, it's been implicated in mood disorders, um, generalized anxiety disorders, panic disorders, ADD, PTSD. A decrease can contribute to depression, a low energy. Increase can contribute to anxiety, hyperalertness, increased startle, paranoia, decreased appetite, and it's been implicated in several mood disorders, as I already previously said, and generalized anxiety disorder, panic disorder, ADD, and PTSD. And also, changes in the neuroadrenergic system have been associated with several neuropsychiatric and degenerative disease processes. Again, it's been implicated. We don't know for sure, but we have a high suspicion. So in Alzheimer's disease, now there's multiple factors that happen right with any disorder. It's not just one. So it's been implicated in contributing, possibly contributing to that. Um, as you know, Alzheimer's disease is the most frequently encountered form of dementia and is characterized by progressive loss of memory and cognition. And one of the proposed mechanisms for this proposed progression is that there's impaired norepinephrine transmission in the hippocampus due to the accumulation of hyperphosphorylated tau and neuroadrenergic axonal degeneration. There's also decreased levels of norepinephrine in the central nervous system, leading to norepinephrine's anti-inflammatory and neuroprotective effects on the central nervous system. And that's just a few of the suggestions for its contributions to Alzheimer's disease. In Parkinson's disease, which Parkinson's is a movement disorder, closely associated with being a cause of dementia. So one of the ways that this can be implicated is that there is a loss of alpha-2 autoreceptor protective effects on the neuroadrenergic and dopaminergic systems. There is also destruction of the neuroadrenergic neurons in the locus coeruleus. In schizophrenia, now we haven't gotten into all these disorders yet, but schizophrenia is a chronic mental illness characterized by a combination of positive and negative symptoms, which may include hallucinations, delusions, blunted affect, inattention, and disorganized thoughts. And although still poorly understood, changes in the dopaminergic and glutamatergic signaling are thought to be the leading cause of schizophrenic symptoms. There is also some evidence of the involvement of the neuroadrenergic symptoms in the disorder, such as elevated norepinephrine levels in blood plasma and cerebral spinal fluid in patients who experience paranoia, and increased markers for norepinephrine in the brains of postmortem schizophrenic patients. So that's kind of interesting. I briefly mentioned this too. So attention deficit hyperactivity disorder, that is a disorder characterized by impairments of working memory and behavioral flexibility, inattention, impulsivity, and/or hyperactivity. Proposed mechanisms for the development of this disorder include the hyperactivity and inattention are attributed to dysfunctional noradrenergic transmission within the prefrontal cortex. And as I've shared and is on the slide, a decreased level of norepinephrine can contribute to depression. So there's a lot that goes on with these disorders, and it's usually not just one neuro hormone that's taking place or causing this. I just want you to remember that, but these are some of the things that we know so far.